It is March 25th, 2026, and today's podcast episode outline is Evidence over Ideology, two psychiatrists on gender dysphoria, mental health, and restoring medical excellence. Hello, I'm Mike Baer with Free Speech Media, and I want to thank the viewers and listeners and my guests, Dr. Kurt Miceli, MD, MBA, and Dr. Stephen Levine, MD. I enjoyed the good fortune to meet them both in Washington, D.C. at the GenSpec Detransition Awareness Day conference, where they both spoke on March 12th. I've shortened down your bios to 30 seconds each, so here we go. Dr. Stephen B. Levine, MD, is a distinguished psychiatrist and clinical professor of psychiatry at Case Western Reserve University School of Medicine. For more than 5 decades, he has specialized in human sexuality, love relationships, and gender dysphoria. He founded the University Hospitals of Cleveland Sexual Dysfunction Clinic in the 1970s, now thriving as the Center for Marital and Sexual Health, and co-founded the university's pioneering Gender Identity Clinic. A former chair of the World Professional Association for Transgender Health Standards of Care Committee, and a distinguished life fellow of the American Psychiatric Association. Dr. Levine brings compassion, clinical wisdom, and unwavering dedication to every patient he serves. And let's do Kurt now. Dr. Kurt Miceli, MD, MBA, is a renowned psychiatrist and chief medical officer of Do No Harm, board certified in both psychiatry and internal medicine. He has spent more than 2 decades delivering compassionate care across mental health crisis centers, substance abuse rehabilitation programs, adolescent residential treatment facilities, and services for individuals with intellectual and developmental disabilities. He previously served as a civilian psychiatrist at West Point's Warrior Transition Unit, as well as in senior executive roles at Elwyn and Bancroft, and as founder and president of Marcroft Associates. An assistant professor of psychiatry at Drexel University College of Medicine, and a first-generation American, Dr. Miceli brings deep clinical expertise, visionary leadership, and an unwavering commitment to medical excellence and patient-centered care for everyone. Okay, today we explore how psychiatry can reclaim evidence-based care amid rapid onset gender dysphoria, comorbidities, and ideological pressures. Dr. Levine, you founded one of the earliest gender identity clinics in 1974, and helped shape early standards of care. Looking back over 5 decades, what key shifts in the field, from psychoanalytic exploration to today's affirmation-first model, have you observed, and when did you first sense the evidence was diverging from practice?
Well, the shift in the early days, in my early days in the 1970s, the vast majority of people were middle-aged males, and the differential diagnosis in those days is this primary transsexualism, or sometimes known as true transsexualism, or secondary transsexualism, often meaning, is this a former transvestite or an effeminate gay man who wanted, to become a woman. So that was really quite clear. We only rarely in the 70s and early 80s saw a woman who wanted to be a man. We did see them, but I would say that sort of 85% of the patients were males. And although we recognized that there was something wrong with these people other than their gender identity, but the best we could do was rule out the occasional grossly psychotic man. But we sensed that there was something fundamentally wrong, and most of these people seemed to fall into our category in the late 70s and early 80s as a character disorder. Now, today, I don't know exactly what I meant, because we didn't have a concept of autism back then. And these were very strange people, and the language we used was character disorder. And we said that most of these were conspicuous character disorders, not just subtle character disorders. But of course, in this century, the epidemiology, the patterns have changed dramatically. We are much more preoccupied with youth. In the 90s, I think there was a concentration on children who are cross-gender identified or gender atypical children. They were 4, 5, and 6 and 7 years old. But today, or this century, I think all of us are recognizing that we have a predominance of girls who want to be boys, and the ratio of boys to girls has shifted dramatically, and that the onset of this seems to be near puberty. And this is a major difference between the 70s and 80s and even the 90s in the last 26 years. So the world has shifted, and our approach to this has shifted. And our concept of, I don't really think we had a concept of science back in the 70s and 80s. All of us were just all of us meaning endocrinologists, psychiatrists, and surgeons, were trying to think, what is going on here? Who are these people? And what should we do about it? And the idea of doing science was best, how many people were happy after surgery? And we would have series of 10 or 18 people published, usually from England, Sweden, but I'd say that our concept of science today is much, much more refined than it was in the 70s and 80s. In the 70s and 80s, we didn't have the concept of evidence-based medicine. And so, people would call me a sexologist or a scientist, but in retrospect, I don't think I qualified as scientific. I was just trying to figure out what's going on here.
You want to follow up, Dr. Miceli?
No doubt, there's been a tremendous difference, and I even look at the span of time which I've been in practice, and I guess it was about 13, 14 years ago. I was working in a residential treatment facility with adolescent girls and boys too, but primarily girls, and the idea of gender dysphoria actually wasn't within any of their diagnoses. Now, granted, I mean, that's anecdotal and such, but I really do wonder that if I were to go back to that residential treatment facility, just a couple of years ago, would that have been different, just in terms of the sort of social contagion that we've seen, particularly in the past decade, and the phenomenon as it's impacted young adolescent girls, as Dr. Levine has said. So I think there has been a significant difference. And even if you look at data from the Journal of the American Medical Association, I think it was upwards of one out of 1,000 girls by the time they're 18 has received a cross-sex hormone. We worry about the rate of type 2 diabetes in youth, which is actually lower than that. And here we have about 1 in 1,000 girls who have received a cross-sex hormone at some point by their 18th birthday. So, the numbers are staggering, and certainly nothing like what was seen 20, 30, 40, 50 years ago. And as Dr. Levine said, a very different individual who is presenting at this point in time compared to what was seen decades ago. And so that should be, cause for concern, and certainly put some flags up as we're trying to care for individuals and really provide the best possible care for them.
Dr. Miceli, as a dual-trained psychiatrist and internist who's worked extensively with neurodiverse and developmentally disabled patients, how does Dr. Levine's timeline resonate with what you're seeing in clinical practice and through Do No Harm's advocacy?
It very much resonates in terms of this rise that we've seen in the past years. And at Do No Harm, one of the things that we've done is we've created the Stop the Harm database, which looks at claims data from 2019 to 2023. And you do see this just tremendous amount of activity in terms of individuals, I should say adolescents, it's not even young adults, less than 18, in fact, less than age 17 and a half, who have received treatments, over 5,700 surgeries, or almost 14,000 individuals who've received such interventions, and that's truly concerning that we've moved to this sort of rapid medicalization, whereas in the past the watchful wait approach may have been the modality with which we would have chosen. Here we see this sort of rapid medicalization, puberty blockers, hormones, and even surgery. So it is vastly different today, the past decade, certainly versus what it was decades ago.
If I can just add something to that, I have a sneaky suspicion that those numbers are undercounts, and that the vast majority, maybe the vast majority of temporarily or permanently identified trans individuals, boys and girls, are not yet on hormones. And so, if we looked at the epidemiology or the prevalence of this problem, we have those numbers that you just quoted, and then we have the group of people who don't make it into those databases because they're not yet on hormones, but or having surgery or are identified in our system. So this is really a big phenomenon, and I think it's beyond our medical capacities to understand. I think we need sociologic and anthropologic and political sensibilities to grasp this. Something has happened across the world to young people as they're redefining skeptically, I think, how to be a man and how to be a woman and what is possible in terms of combining male and female elements into a cohesive sense of self. My great concern is that it's not possible to have a cohesive sense of self, but that remains to be seen. And the truth is, we don't know the outcome of this epidemiologic surge, so we don't know how these kids are going to prosper or not prosper in their 20s and 30s, although I have enormous amount of fear about that.
Interesting. Now, what do you think that number is for each person identifying as trans that's taking the hormones? There are 6 or 10 or 20? Do we know?
I'm just quoting one particular worker who I think Dr. Martinez, who suggested the ratio was 9-1, but I'm not sure these are just guesses. Perhaps Kurt, you know better than I do about this.
Yeah, that's similar to what we've seen in terms of those who may engage in social transition, but yeah, it's largely I think a definitive number isn't known, but certainly much greater than the amount that have received hormones, puberty blockers, and the like.
I think to be really honest about this, which I think all of us have to commit ourselves to it, the most common answer to major questions is I don't know. I don't know how many detransition. I don't know what the actual prevalence is. I don't know how many people for how long maintain this identity and then give it up before they even take hormones. I don't know. I don't know. I don't know. And to me, that's a trustworthy statement because there's a lot of certainty, which I think is unjustified.
Well, we all know that we're all human beings and we all want love. There are some things that we do know.
Well, the question is transgender identity a good strategy for obtaining love?
Very true, very true. Dr. Miceli, your background includes treating patients with autism, intellectual developmental disabilities, and complex psychiatric needs. In your experience, how often does gender dysphoria overlap with these conditions? And why is a full psychiatric and medical workup, including ruling out trauma, autism, or other mental health drivers, essential before any medical intervention?
And thanks for the question. It's the work that I had done with folks with autism, intellectual development disabilities, had often been in the human services sector. And so these were individuals who were living with us, and oftentimes because of significant behavioral challenges that they may have had, and helping them to live a full and healthy life. And so oftentimes some of those challenges may have been significant self-injurious behavior in the way of headbanging or doing other sort of self-injurious activity, not related to gender dysphoria or anything of the sort. And so that was always our primary concern. How do we keep someone safe? And we would have folks who potentially headbang to the point of actually detaching their retinas. And so significant self-inflicted, again, not volitional by any means, but just trying to obviously keep people safe in that environment. And so it was more so in the insurance side that I had heard more about, like, hey, you need to have an affirming environment. You need to provide these other sort of modalities and treatments. And I thought to myself, wow, these are not the individuals that we're caring for. Again, it's a segment of the population, very different. But truth be told, when we look at individuals with autism, and autism is a very diverse, I guess, diagnosis, and so you will see lots of different individuals with different sort of shades of autism and such. And we do see that diagnosis does have a much higher association within gender dysphoria, and some say 3 to 6 times as much. And that should be cause for concern, because we know that folks who have autism experience the world in a different way in terms of the cognition and how they interact, their social communication. And are we as clinicians then misinterpreting how that individual with autism is experiencing the world? And are we incidentally placing sort of a gender dysphoria frame on it? If they experience distress or confusion about getting along with peers and such, are we then misinterpreting that as, well, they must be the opposite gender? And that would be foolish, and that's why it's key to have absolutely full comprehensive assessment. And that goes for anything in psychiatry and medicine, right? You don't want to jump to a conclusion, no matter what the patient may say before you. It is our job as the professional to provide that full and comprehensive assessment. And again, I think even outside of this question of gender dysphoria, that unfortunately has become more and more pressured with time pressures that clinicians have in the clinical setting, feeling sort of rushed because of RVU, these units that you have to generate in order to meet your metrics and such. And that unfortunately has created this environment where we tend to move perhaps a lot faster than we should. But this is so critical, especially with vulnerable populations. It is so critical to make sure that we have the diagnosis correct, that we truly understand the person, that we're not just throwing a label out there, misdiagnosing folks, and then leading them on a pathway that is truly harmful. It's critical for us to get that assessment right. When you go into the doctor's office, you want to make sure that they're treating you for what you have, not what you may think you have. And if it's pneumonia, let's treat pneumonia. If it's congestive heart failure, let's treat congestive heart failure. But let's not. Let's use that professional judgment in figuring out what the shortness of breath is and what its etiology is. And that's the same approach that we need to take, especially when it comes to issues within psychiatry, within behavioral health. So there's a real call to muster up the time and the energy to do that, and then to apply the appropriate treatment. That the treatment, again, doesn't need to be rushed or medicalized in any sort of way. We should take that time to really understand the individual through time, and so allow ourselves the ability to get to know the individual, to get to know the comorbidities that they're facing, the predisposing factors, all of those different things. And that takes time. It takes time to develop that relationship with the individual. It takes time to build that trust. It takes time to understand. And unfortunately, in a society that's often looking for things quickly, that can be a difficult position. But it's our responsibility as the professionals to do things right, and obviously to do no harm.
So can I just add something to that wonderful answer? I'm particularly interested in the mechanisms of how we become what we become, how we think what we think. Now, I have used the word psychodynamics to explain mechanisms. To me, psychodynamic is a synonym for the mechanisms of production of behavior or thoughts or feelings or identity. It's what I call the psychodynamics. So what we're talking about, what's going on here is also about the comorbidities. But the question becomes, how do the comorbidities relate to the psychodynamics of the identity, of the new identity? You see, because it's not either you have transsexualism or gender dysphoria or autism. Autism predisposes, I think, to the solution that I am born in the wrong body, etc. So I just think my bias about this, or my inclination, is to try to understand The answer to this question, what's going on here? How did this get produced? And what are the consequences? And what can we do about it? And of course, I was nodding throughout the doctor's answer to your question, because this begins with a comprehensive evaluation, and this is not to be rushed. And we have to figure out how to create a enduring relationship with the family, with the parents and the child, or the teenager, or the young adult, or the middle-aged adult. You see, because even the 50-year-old who's decided he wants to be a woman or she wants to be a man now, the question, why? What's going on here? What has changed your mind? What are you trying to solve? You see? So I think even if we're talking about a 4-year-old or a 14-year-old or a 44-year-old, we doctors need to be able to answer the question, what is the pathogenesis? What is the psychodynamics? What is going on here? So
No, I love that, and it's really that curiosity that we need to have, and heck, that's what really made me very interested in psychiatry, is because of that curiosity of understanding the behaviors and why we do what we do, and yeah, at times you may never figure that out, but that's the quest that we really need to be on. So thank you for that.
yeah, we leave it as these are hypotheses. We don't know exactly how to prove things, but sometimes the patient reverberates with our interpretation and recognizes this is true. And that sometimes can catalyze a behavioral shift, a shift even in identity. It either strengthens the identity or weakens the identity or has no impact on the identity.
Dr. Levine, you've written extensively on the psychological roots of gender dysphoria. How would you advise a clinician hearing Dr. Miceli's point about neurodiversity? Does the current gender-affirming shortcut risk missing treatable underlying issues?
Yeah, I think for many of the people on the spectrum, and I tend to see a lot of very intelligent people on the spectrum, and I see that they have a kind of sociologic suffering, a suffering that has to do with their relationship to other peers. And the sense of being on the margin, or as one of my patients says, I felt invisible to my peers. I was there, but no one seemed to regard me. The pain of social isolation, of not fitting in, especially in adolescence, when all adolescents normally uh, their self-esteem is somewhat related to how their assessment of their social worth in terms of peer acceptance, and the friendlessness that is often accompanying autism, I think, creates the need to belong to some group of people. And so if you go on the internet and you talk about you're not comfortable with your body, you don't have friends, some authority is going to say, well, maybe you're trans, or you are trans, or this is a typical thing of trans people. And suddenly you belong to a virtual community. As parents use this term, my child is love bombed on the internet, and all of a sudden feels accepted, and that solidifies this identity. And any then parental pushback, they're getting the information on the internet that your parents are transphobic, and they're hateful people, they're the enemy, and that just makes everything worse. You see, so this is again Dr. Levine trying to figure out how these things work. What's going on here? What is the step? What's the psychodynamics of this? What's the mechanism? You see, and I think that's the secret to the therapy, is to be interested in that question. And it doesn't matter if someone has having panic attacks, it has nothing to do with gender dysphoria. I'd be saying the same thing.
Dr. Levine, you've testified in major cases and reviewed the data on puberty blockers, hormones, and surgery. What does the emerging international evidence, CAS review, European shifts, tell us about desistance rates, regret, and mental health outcomes when psychological care is prioritized first?
Well, actually, I think the answer to the outcome data is I don't know. Um, we are quite aware of the phenomenon of detransitioning, but we don't know the rate of detransition. We don't know, how many years is the typical number of years before someone is able to say, I made a mistake. And we don't know how many people who say they made a mistake, but it's too late as far as they're concerned. And so they still live in a trans way, but they wish they weren't. So these are questions that I think none of us have a clear answer to, but we're growing more and more aware and more curious about it, and at least some of us are able to acknowledge the possibility that these things happen, that the outcomes are not that what percentage of people live happily ever after, and what percentage of people are miserable, and what percentage of people develop psychosomatic or depressive psychiatric problems as a result. But I think in the first part of your question, the answer is from a data point of view, it's not clear that the promises of puberty blocker, cross-sex hormones, mastectomy, and vaginoplasties deliver improved mental health. It's not clear. The evidence is very of low certainty or very low certainty. And given the efficiency of affirmative care, the evidence being of low certainty should cause everybody pause. Wow, let's take a step back. Let's re-examine this. But that's not what's happening in the United States, in at least some states, and that is what is happening in Europe. Europe is way ahead of us in this regard. I but it's politicized even in other countries. But I don't know. Maybe United States of America has more intense politicization of this issue than any place. But I mean, it's a worldwide phenomenon. I don't know if I answered your complex question, but that's my response.
It was good. Dr. Miceli, from your healthcare economics lens and work at Do No Harm, why are claims like puberty blockers are reversible or this prevents suicide particularly misleading? And what economic or systemic costs are we seeing?
Yeah, well, I think one of the things, much as Dr. Levine said, is that the evidence is of very low certainty. And so when we make claims that are so bold, well, they need to be grounded in evidence, and they're just not. That's the real challenge there. And we know that individuals, when we look at data from Finland, for instance, we know that it's the behavioral health conditions, those comorbidities, that are driving the suicidal thoughts that one may have. And so it even gets to the importance of treating those depression, anxiety, those comorbid psychiatric conditions that are the drivers of the suicidal thoughts that one may have, and focusing on those very clearly and crisply. When I look at the puberty blockers, we know that puberty blockers do impact bone mineral density in a negative way by making bones weaker, causing things like osteopenia or osteoporosis. We are concerned that there may be cognitive effects as well in terms of what puberty blockers do, and we know that there's impacts on fertility, especially if you then take cross-sex hormones thereafter. And so those are concerns. And then to sort of say that this is irreversible, or reversible, I should say, is just wrong, right? We know that these are impacts. But even to look at the lens of taking a puberty blocker while other peers are going through puberty, what does that do to the individual and their own experience as their peers are going through a natural process of puberty and they are not, because they're taking a puberty blocker? And it may very well, as Dr. Blaine says, it sort of starts reinforcing identities that have been created and manufactured, as opposed to what is actually the truth of one's humanity and what would happen if allowing nature to do what it would normally do. So I think there's real concern there, and certainly from the economic lens. I mean, we know that that unfortunately, in many sort of voices of a pro-affirmation movement, that it's the benefits that get highlighted without any mention of the risks. And it's important for us, again, as physicians, to look at our ethical principles, to understand that we need to first do no harm. And when we look at the risks, we recognize that the risks are significant. And again, the evidence of any sort of benefit in terms of mental health outcomes is very low. And so that really should make us look at the calculus and understand that the risks are significant. And much as the American Society of Plastic Surgeons has recently recognized, those risks are so great that we shouldn't be doing these procedures in children because of the real challenges that we understand with them. So I think there's a lot of obviously a lot of concern and a lot that we really need to do. And getting to one of the other points that Dr. Levine mentioned in terms of detransition, I think it is certainly true that we don't know the true rate of detransition or regret. It's one of the reasons why we've petitioned the CDC to look at creating codes that can at least help to get this into our diagnostic vernacular. And again, that will certainly entail the importance of then people using those codes, but it could give us helpful information in a real world sense. So, we have a keen interest in making sure that we can create visibility for those who've detransitioned, and thereafter create treatment guidelines, certainly to help and to assist. And there are folks that are obviously doing this already, which is so needed to help folks who are in detransition. And then likewise, also make sure that we're collecting the research to understand what the actual rate is, why people, what is going on. Again, having that curiosity to truly understand so we can better help individuals.
Dr. Miceli, organizations like the APA and the AACAP have faced criticism for limiting debate on these topics. As medical director at Do No Harm, you've pushed for open scientific discussion. What barriers have you encountered, and how can psychiatrists reclaim their role as objective evaluators rather than affirmers?
Well, I suppose I was really fortunate to have gone to the APA meeting in May of last year. That's where I had the opportunity to meet Dr. Levine in person and to meet others. And it was a wonderful event. And to actually be able to see Dr. Levine and others present within the scientific program on this issue, on the European data, to really help open the eyes of the clinicians that were there. And likewise, Do No Harm had a booth, an exhibit booth within the context of the exhibit hall, where we could encounter psychiatrists. They could come to us to have a conversation. And what we found is that many of those psychiatrists were very much in support of our position. And I think in some sense, maybe fearful of saying anything more publicly, but it was reassuring to know that psychiatrists do understand the importance of a good clinical assessment, do understand the data, and likewise to educate others on the data, to educate others on the HHS review and reports, the CAS review, and other data that's out there, again, showing the very low evidence of benefit. So I was very hopeful coming out of that meeting, and our hope was that we would be able to continue that conversation at the American Academy of Child and Adolescent Psychiatry, ACAP, as you mentioned. They had their meeting in October of the past year, and we did apply to be an exhibitor there, but unfortunately, what we found within a month or so of the actual meeting, that our exhibit was canceled. And so we applied again because we weren't really sure why it was canceled. We thought maybe there was some error in the credit card processing or something of the sort. So we applied again, and we were canceled again. And I reached out to some colleagues that I know at ACAP to understand, well, hey, what happened here? Help me understand. Is there a mistake? And what we came to find out is that at that meeting, they wanted to only speak about gender dysphoria within the scientific program, and to have no such conversation on the hall of the exhibit, which really had me scratching my head, because the exhibit hall is then filled with pharmaceutical companies who are marketing all sorts of things. And it made me think that, wow, so we're okay with pharmaceutical companies doing whatever they want in terms of marketing and promoting products. We don't want to restrict that to the scientific program, but here we're actually aiming to present data that is out there, systematic reviews of the evidence, and that we can't do. That has to be within the scientific program. So it was just a truly bizarre and contorted logic, and that's the kind of silencing of debate that is truly concerning. And we need more conversation within medicine, because certainly the the public understands the gravity of the issue. When you poll individuals, whether they're Republican or Democrat, they understand that kids shouldn't be getting puberty blockers. They understand that there are risks and harms to these interventions. They understand that cross-sex hormones aren't a cure-all. The public understands that. And again, common sense, ordinary physicians understand that. But unfortunately, there are many within the I guess the academic leadership that are struggling with that and perhaps captive by activists in the sense of not allowing an open dialogue, an open conversation, being very hard to get articles published within academic literature. So I'd certainly say Dr. Levine sort of broke a barrier there by getting into the APA, by having the scientific discussion. Yeah, there was lots of rules and regs about it that I'm sure he can share here. And there was an opposing view that had to be had within the halls, but at least the offering of European data to provide the exemplary evidence was there and was made clear, and it was a room that was filled. It was filled with folks, and it was great to see that engagement and that activity, because again, I think psychiatrists in general are yearning for this information. They are yearning to understand. Ultimately, we go into medicine because we want to do the right thing for patients. And it's important for us to have the evidence to understand it in order to provide the right treatment. So there's a lot more work that needs to be done, but I'm often inspired when I do speak with colleagues. Just last night, had an opportunity to speak with about 15 or so psychiatrists from across the country, and they too sort of echo the concerns that we have, and look at the data and worry about sort of the maybe reductionist logic that our society in general, but certainly psychiatry, has found itself in, where we more so are looking at the organs and reducing people to a reflection of their heart or their brain, as opposed to looking at the whole individual. And I think if we can continue to speak this conversation where we need to understand the whole person, we need to be curious about who they are, what they're encountering. I think as we continue to engage in that regard, and we continue to raise our voice, and we continue to have this dialogue, more and more other psychiatrists and other clinicians will continue to recognize that, yeah, that's why I went into medicine. That's what I'm here to do. And I think they'll really the hope is for this great awakening within the halls of medicine, because there is much more that we have to do to be on the right side of this issue. And currently, we see the encouragement with the plastic surgeons and what they've done with their specialty society, but there's miles to go before we sleep in terms of bringing the house of medicine all to the evidence and doing the right thing for keeping kids safe.
There's probably no one who's ever expressed any skepticism about the sort of best practices, affirmative care. There's probably no one who hasn't experienced the cancel culture. As you were saying, you couldn't get a booth. Everyone I know who talks about these things have been canceled, rejected, papers not.
Well, that's a new experience for you. You're used to having everybody, please come and sign my book.
Yeah, right. I often say I was used to being a sort of valued member of my local community, and even in my department of psychiatry in 2022, when we published this paper called Reconsidering Informed Consent, all of a sudden I became the residents, and the residents knew how to take care of these patients best, and they thought I was a subversive guy and refused to allow me to teach them in basic human sexuality, even though I'm the editor of one of the textbooks in human sexuality. So this cancel culture is really powerful, and I'm glad to hear Dr. Miceli maintains optimism, because I think, in fact, in the last 5 years, we're making a headway in bringing this question: what is going on here, and are we doing the right thing, and what about our medical ethical traditions? Well, what's going on here? Have we gone crazy? So these are important things, and I think we do have to maintain optimism about this. But there are lots of people who think we're terrible people.
Dr. Levine, you contributed to early WPATH standards, yet now advocate caution, especially for minors. What advice do you have for younger psychiatrists navigating institutional pressure versus patient-centered care?
So the soul of science philosophically is skepticism. We need to be aware that in order to pass one's boards, in order to get credentialed, if you look at the DSM-5, I'm just going to invent a number for you. There are 275 categories of illnesses, psychiatric illnesses. In order to get board certified, you have to know a certain amount about how to recognize these quote disorders and how to treat them if there is a treatment. You are taught something and you have to regurgitate that. This is not skepticism. This is learning, so to speak, what the current concepts are. Now,
Dogma.
the truth is that much of that information is not correct. And certainly the people who get board certified, the young psychiatrists, for example, they have to trust that what they've been taught is useful, pragmatic, and scientifically correct. And then they get out and they go practice and they see that these medicines or this form of psychotherapy or this patient really is having a negative outcome. You see, I'm not very good at this. And you think it's your defectiveness as opposed to not understanding what the problem is that the patient's presenting. So you become skeptical over time. And so I think the real issue is, how do we teach skepticism? How do we change? This is what we know, but facts change, and doctors who are well-intentioned can be wrong, and they're not terrible people. The people in affirmative care are not terrible people, but they think they're helping people. And so the skepticism is the important issue. And I think as we get older, we don't have to get much older, we get skeptical. We're taught, if you grow up in a cognitive behavioral department or a psychoanalytic department or pharmacologic department, whatever you're taught, you very soon discover you're not that powerful as a curer of mental illness, and your ideologies have limitations. You see, and that's why I think what I said earlier, when we have these wonderful explanations and when it's all said and done, they're hypotheses. They're humble attempts to understand, to illuminate, to help the patient understand what they're struggling with, you see. And it's a humbling experience being a psychiatrist. And so when people are passionate and arrogantly certain, I think they have a insufficiency of skepticism. I don't trust passionate, certain people.
Well, some of them seem to be true believers, that's for sure. Dr. Miceli, given your extensive work in developmental disability clinics, why is the dramatically elevated rate of autism among gender dysphoric youth a red flag? And how should treatment protocols differ for neurodiverse patients?
Well, I certainly want to echo what Dr. Levine said about humility. I think that is so important, to recognize your own limitations as a clinician and understanding someone. And I think there's so much to be said for that, and having that humble approach as you approach the individual to learn more about their experience and who they are. The question on autism and such, I think it's just so important for us to understand that cognitive, the social, the emotional aspects that might impact one with autism, and how distress may be experienced or expressed or interpreted by somebody with autism. And I appreciate what Dr. Levine said earlier about this idea of social belonging and struggling with social belonging, and looking and seeking communities, and certainly having someone who is potentially so vulnerable, finding a community that quote unquote love bombs them and accepts them, and then creates almost a brainwashing of some sense as to what their thoughts are. That's concerning, and I think it's important for us to understand that about the individual who has autism, to understand again that the cognitive, how they perceive things, whether through a very literal sense, and may perceive a not fitting in as a mismatch. How do we understand that distress, and how can we be more curious about it to truly find out what is at its root, or perhaps the interest that one has. We know that individuals with autism oftentimes have preoccupations, or they might have sort of obsessions or such. And are we misinterpreting those preoccupations and obsessions that might be with certain themes or certain clothing? Are we misinterpreting that as gender distress or their sensory preferences? Are we misinterpreting that? I think these are all considerations that we need to understand, and even how the individual with autism may communicate. If their language sort of echoes or repeats what we have to say, are they telling us things and then we as the clinician are misinterpreting what they're saying? Are we sort of putting them into a category as opposed to understanding the whole person that's before us? So it's incumbent upon us as the clinician to aim to garner more information, to look at the lens by which the individual is looking through, and again, not to mislabel. And so I think, to your question, this idea of a red flag, yeah, it should certainly raise a red flag. Are we appropriately understanding the individual and how their experiences are, or are we just sort of throwing them into a box and categorizing them, and then unfortunately pushing them into a series of procedures that end up in this medicalization model? So it is critical to get this right, to understand the individual, and that requires more time. It requires a slower, more thorough approach. It requires us to be more exploratory in our methods, and also to involve, again, certainly with a child, the family, to understand what's going on in the home, to have that full comprehensive view, and to help carefully differentiate between what is gender dysphoria versus what is perhaps autism-related distress, to understand the nuance that's there. That takes a professional, and again, as psychiatrists, that is what we're called to do within our professional capacity, as opposed to just quickly labeling someone and pushing them on a path that just leads us to significant harm.
Dr. Levine, you've long emphasized that gender identity is only one facet of a person's psychology. How does Dr. Miceli's clinical observation align with your decades of seeing patients who later desisted or found relief through therapy rather than transition?
I have not disagreed with anything Dr. Miceli has said, so it aligns very well. We just met each other, but it seems like we live in the same universe of skepticism and concern. Um, so, so repeat your question for me, the other part of the question.
Sure thing. How does Dr. Miceli's clinical observation align with your decades of seeing patients who later desisted or found relief through therapy rather than a transition?
It's not only those who desist. I see people who persist, but it aligns. They understand their lives now. They understand that perhaps their life would have been different if they met some other kind of. I remember one of my patients came to see me after seeing two therapists that helped with his transition in his 60s, and he realized that both of them were merely cheerleaders, and he wanted to come see somebody to help him understand what was happening in his life. You see, why did he do this? So it's not just the detransitioners who are interested in what Dr. Miceli is talking about, and I just think all of us, even all of us, forget the gender atypical. All of us are curious eventually about what shapes our behavior, our style of being, our tastes, our sexuality. So what we're doing is trying to promote self-awareness and psychological awareness and autonomy and skepticism and knowing that there's ambivalence about most human activities, you see, and we don't want to make gender dysphoria an exception. I like to say that I'm a very smart man. I like to say to a patient, a 14-year-old or a 16-year-old, I'm a very smart man. And I know that you think the most important thing about you is that you're trans-identified, but I think the most important thing about you is that you're a human being, and that all things that are true about human beings are going to be true about you. And then eventually, as we have a relationship, you see, then they come to see that they're, like all human beings, they're uncertain, they're ambivalent. Even when they say they're sure, I kind of warn people not to be certain, not to be certain about anything, right? So, you know, uh, Toni Morrison, the Nobel laureate in literature, was asked about her identity, and she laughed and said, "There are hundreds of pieces of me." So I sat down, I heard this, and I said, "I'm going to count the pieces of me." And I can only identify 35 pieces of me. And so I list 35 things and I say gender identity is one of 35. Or if I listen to Toni Morrison, one of hundreds. You see, and what I'm saying with that anything is true about humans will be true about you. There are multiple aspects of identity, and every aspect of identity evolves with maturation. You see, my sense of myself as a boy and as a man has been very different as I've aged. You see, my sense of being a masculine person and and having feminine aspects of me is evolving all the time. So, so I just think, listen, these are human beings. Let's treat them like they're human beings. They're not special exceptions, you see. They're struggling with some aspect of identity. See, when people struggle over their political identity or their religious identity, we don't make that into a big deal. But that doesn't change their anatomy or physiology. This is a big deal because we have immature people changing their anatomy and their physiology and their future when they're 13 years old. So this is an ethical problem, and it has to do with what Dr. Miceli was saying, is our responsibility to help the person think clearly and to remember these are kids, 13 years old. Take a picture of a seventh grade class, a sixth grade class, an eighth grade class. This is what we're talking about. You say that these are not wise people yet, and that yet they're making crucial life decisions.
Dr. Levine, what one message would you leave for the next generation of mental health professionals?
Trust why you went into mental health work. You're interested in people, and trust the fact that you need to be skeptical, and that people are not going to tell you everything that's important and everything that they know the first time they meet you. And trust. I'd like you to trust me for a minute, young mental health professional, that every time you meet a patient, there is a chance that you will understand their life differently. Every time, every session gives you the opportunity to understand how rich and complex their life is, and what they're saying and what they're not saying, you see. And so enjoy your ambition to be a helpful mental health professional. Keep humble. Don't be certain.
Thank you so much. Dr. Miceli, from your internal medicine and psychiatric dual lens, what medical red flags, such as bone health, fertility, cardiovascular risks, should every psychiatrist flag when considering referrals for medical transition?
Well, I think you've mentioned a few there, certainly, and frankly, I'd even sort of step back as if one is a child and we're considering any such interventions, I would really sort of caution us on that pathway. In fact, I would recommend that we not refer to medical transition for all the reasons that Dr. Levine and I have shared. But there are important medical considerations in addition to the ethical, professional, and other considerations. And so, yeah, we do know in terms of puberty blockers, their impact on bone mineral density, their impact on fertility, their possible impact in terms of cognition, the fact that peers will be experiencing puberty while this individual isn't. Or if we look at cross-sex hormones and we look at the fact of the cardiovascular effects or the worsening of cholesterol or metabolic syndrome that might be occurring occurring, or the cancer increased risk that we see. I mean, there's significant factors here, again, just purely from a medical lens. And I recall at the event that we were at, Detransition Awareness Day, there was one detransitioner who spoke to the fact that she had, and she was an older individual, that she had, I think, 4 or 5 heart attacks in her 50s, and that was she was taking testosterone, and that's a real risk factor. I mean, obviously, we know that men in general have heart disease at much greater rates than women, and testosterone is a significant factor in that. So, putting such exogenous hormones into one's body as a biological woman would certainly create those difficulties, and that was something that she experienced and relayed to the audience. And so I think there's so many of those considerations that are also out there, but mostly, again, much as we've said, in terms of the child, in terms of the minor who is going through a period of distress, how important it is for us to be curious, to understand what's going on, to really allow the psychosocial interventions to help that individual as one explores with them, and really helps them to gain the comfort with perhaps the discomfort that they might be experiencing, the resilience that they need, the strength that they need. There's so much that we can offer and we can provide, and so I would hope that that clinician treating that child would not want to just quickly funnel one to a gender clinic or through a transition process with medicalization, but instead really treat them as the individual that they are and offer those psychosocial supports and that healing that can really come to the mind and help them through a challenging time.
Jared, what gives you optimism that psychiatry can course correct towards evidence and compassion?
When I talk to medical students and residents, I just see tremendous optimism and hope as to why they do what they do. And they aim to go into the field for the right reasons, in terms of wanting to help people, that desire to place evidence and data into practice in real situations, to be compassionate. Again, having just spoken to a few psychiatrists last night on a Zoom call, it was just so wonderful to hear their expressions of humanity, and how they see patients and how they see them in terms of the relationship, and understanding the relationship and the factors that one goes through as one walks through life, and to help someone along that journey. And frankly, what I've certainly found in my own practice has been that experience of learning so much from the patients that I've been privileged to treat, and to recognize that it is such a privilege. So there, in my mind, there is a lot of cause for optimism. No doubt, we certainly have a lot of work to do, but I'm certainly encouraged when I see the American Society of Plastic Surgeons come out with a statement whereby they've looked at the evidence, they've looked at the ethical principles, and they've said that these procedures are not procedures that we should be doing to minors. But they've also placed some concern with the endocrinological interventions. And granted, they're plastic surgeons, they're operating and doing surgeries, but they also flagged for us concerns with those, again, endocrine medical interventions. And that's important for everyone to hear. And my hope would certainly be that the Endocrine Society, the American Academy of Pediatrics, the American Psychiatric Association would lean into that. And again, when I spoke with members at the American Psychiatric Association, many of those folks who came to our booth very much understood where we were coming from, were eager to learn more, want to look at the data, want to place that data into practice in terms of providing the psychological and psychosocial interventions, and not engaging in the medicalization. There's lots of hope there. I think we just really need the medical societies to, in essence, wake up and recognize that we can't allow activists to move those societies forward. And so, ordinary, everyday docs need to engage and get involved, and maybe in some sense re-engage with organized medicine to help turn the tide. And I think as we continue to do more and more of that, we'll see more and more reasonability and good practice. And we need it, frankly. We need it because not only do we need to make sure we're keeping children safe, keeping the vulnerable within our care safe, helping those who've been harmed by medicine, but we also need to restore the trust within medicine. We need to make sure that we show people that we are the professionals that we say we are. And when we do that, I think we'll start building those bridges, and we'll start moving forward in a much better way. So more to go, but I certainly remain optimistic based on the tremendous movement that we've seen, even just in the past year or two.
Wonderful message. Again, I want to thank the viewers, and I want to especially thank my guest today. Very grateful to you all. Check out the description below for links to the cast review summaries, Do No Harm materials, and Dr. Levine's writing. And thanks again for listening.